All right. I want to welcome everyone to the Agency for Healthcare Research and Quality's national webinar on Prepping for the Future, Digital Solutions for Aging Populations. While people are still logging in, I'm going to get us started. My name is Kevin Chaney, and it is my pleasure to moderate today's webinar. I currently serve as a Senior Advisor for Dissemination and Innovation for AHRQ's Digital Healthcare, or AHR, program, which is part of the Center for Evidence and Practice Improvement. DHR's mission is producing, disseminating evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients, their caregivers, clinicians, and health systems. We will discuss 3 of these exciting research projects that we have funded during today's webinar. Here's the agenda for today's webinar. Please note that we are recording the webinar and that the recording and slides will be available on the DHR website in a few weeks, and you will be notified by email once they are available. We are pleased to have with us today an esteemed group of presenters, including Dr. Z. He, Dr. Valerie Press, and Dr. Jorie Butler. This webinar is accredited by Affinity CE. If you're interested in receiving the free continuation credits for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. And for the purposes of accreditation, let me note that AHRQ, our contractor, SD Solutions, and Affinity CE have no financial interest to disclose, and Drs. He, Press, and Butler also have no relevant financial interests to disclose. Please note that no commercial support was received for the development of this learning activity. So some important details for those of you who are joining, and it's just a brief note about questions. We have reserved time at the end of this presentation to address participant questions. However, during the actual presentations, if you have a question that comes up during a particular slide, perhaps for a certain point, feel free to submit those questions that you have, for the presenters using the question and answer, the Q&A panel located to the right of the PowerPoint slides. Please include the presenter's name or the presenter order number, if possible, first, second to third presenter with your question. That helps us also distinguish in case we don't get to every question. We do our best to try to go back and answer those. We just ask if you can, it helps us make sure that you're going to get the right answer from the right person. As a reminder, participants are in listen-only mode, so to ask questions, you need to use the Q&A panel. This slide is outlining the learning objectives for today's webinar. By the end of this presentation, you should be able to identify key design principles for developing older adult-friendly digital health tools that integrate electronic health record or EHR data and natural language processing to support personalized health communication and shared decision-making. You should also be able to learn or be able to describe how telehealth-enabled transitional care models can improve medication adherence, self-management, and health outcomes in older adults following hospital discharge. And you should also be able to explain how mobile apps and smart on-fire-enabled platforms can collect and integrate patient-generated health data to inform clinical decision-making in age-friendly care. And now it is my pleasure to introduce our first presenter, Dr. Z. He. Dr. He is a professor in the School of Information and director of the Institute for Successful Longevity at Florida State University. He is also director of the Biostatistics, Informatics, and Research Design program. His research lies in the intersection of biomedical and health informatics, AI, and big data analytics. The overarching goal of his research is to improve population health and advance biomedical research through the application of informatics using EHR data from heterogeneous sources. And with that, we will hand it over to Dr. He.
Thank you so much, Kevin, and for inviting me to be part of this wonderful panel and presenting our research in this opportunity. I'm today very honored to present our AHRQ funded project called Lab Genie, and which is focused on using artificial intelligence and the user-centered design principles to develop applications for empowering older adults to participate in shared decision-making with a better understanding of their lab test results. So the research impact we're trying to make is by making lab information easier to understand using AI, Lab Genie empowers patients to ask better questions, make informed decisions, and also play a more important role in their healthcare. So as many of you probably already know, under HIPAA and the 21st Century Cures Act, patients now have a legal right to access their lab information immediately when they're available. And often this information are given to patients before clinicians have opportunity to review them. And the policy kind of shift also has clear benefits. It promotes patient engagement, empowerment, increased transparency, supports more timely decision makings. At the same time, this can also improve health literacy as patients now have a better access to their data and get more familiar with their data. At the same time, they also introduce some challenges. Patients may experience unnecessary anxiety when they see abnormal values without explanation, lack of clinical context needed to interpret the results correctly, and rely heavily on online searches to find information that potentially may be misleading, and also make premature decisions before talking to clinicians. So this create a research gap between access and understanding. So as many of you already have access to the patient portals, it is reported that accessing lab results is one of the most used features in patient portals. And however, over time, we also have seen lab information being presented in different formats, from tabular format to visualization format. So currently, many current modern patient portals using this type of visualization to indicate your values in the spectrum of value ranges so that patients have an easier and better understanding. But still, because this information is lack of context and lack of interpretation, to ensure that patients have an accurate perceived urgency and the interpretation, it still become it's still a challenge for patients to fully understand the information behind those numbers. Previous research have done quite a lot of work has been done to understand how patients receive information such as lab results and what we do. And they found that many patients actually don't receive any explanations, and about half of them actually did online search to better understand them. And compared to the table format, visualization using those color bar graphs reduce patient perceived urgency and desire to contact healthcare providers, even if some of the results may need some attention. So in our previous research, we also have done a mixed methods research to understand patients' needs in understanding lab results information. So we found that patients oftentimes they want, besides general information, they also may want personalized contextual information, including treatment options, prognosis, and guidance on next steps, and also questions they want to ask their doctors. And recently, we also have done a survey study to understand the older adults' challenges in understanding lab results. Even though, generally speaking, older adults have a better understanding of lab results, but they also have difficulty interpreting results on their own, and they oftentimes prefer to have doctors explain the results to them. So, also for older adults, the interpretation of lab results could be more complex because interpreting blood lab results required a nuanced approach due to age-related changes in blood chemistry, and also as patient age, common shifts such as hormonal fluctuations, lower blood cell counts, and altered organ functions could occur. And there are no standard reference ranges for older adults, and doctors oftentimes use the trend and abnormal values rather than relying solely on standard reference ranges for adults. And overall, various studies have shown that there's a clear need for contextualizing information that goes beyond normal numbers. And the goal for the Lab Genie project is to develop and design and evaluate this application, which is a web-based patient-facing tool that presents lab information in a visualization format, and also providing contextual information and offer personalized question prompt, so patients will have a better understanding of the lab results and also can be better prepared to follow up with consultation with their doctors. So the major research questions we want to ask is, how can we improve older adults' ability to comprehend their lab results tests, and how can we improve their confidence to participate in shared decision-making with doctors? So this is our funding project as R21, R33 mechanisms. So in the R21 phase, we're developing and designing and using user-centered design approach with this prototype. We include patients and physicians in this design development process. At the same time, we also are leveraging generative AI technologies to develop question generation modules to integrate electronic health record data and also be able to contextualize information to generate tailored information and a question prompt patient can follow up with the doctors. So with this prototype, we have evaluated their potential usefulness and also intention to use. And then when we move into the R33 phase with a working prototype, we would like to evaluate with the real patients their effectiveness of this AI-generated content in improving their understanding and also improving, more importantly, their confidence in shared decision-making in a one-shot study, randomized control study, as well as the mixed method longitudinal sequential studies to recruit real patients, let them use the application for 6 months, and then evaluate all these health outcomes and behavior outcomes before we move on to the large-scale study in the future. So just want to give you some ideas about what kind of user-centered studies we have done. So we have done 2 phases of participatory design studies, where in the first phase, we collect information from patients about lab results information on visualization styles. And then we conducted also online experiment to evaluate whether tailored information or contextual information compared to generic information could give people a more accurate interpretation of lab results urgency and also intention to follow up with the doctor. And then with this information, we refine the applications, especially refine the UX UI part of application to make sure that application is has a certain level of usability and acceptance. And then in the design workshop second phase, we're evaluating the features, interactions, and then we're prototyping this application, leveraging all this information collected. So we work very closely with our local communities by recruiting participants through the senior center and also conducting the design workshops at the senior center so patients can have easier access to these resources. So in the first design workshop, we set up design workshops. We also collaborated with my collaborator at New York City, where we also recruited from New York City's locations. And then 17 participants participated in the study, and many of them had experiences with using technology to view lab results, but many of them actually found it still difficult to interpret the results. So in the first design workshops, we focus more on the visualization styles, where we give them different comparison group to ask them questions around the different type of comparison. So we focused on color, and we focused on grading color versus solid color band. We also focused on different labeling and the goal range. And it's interesting that we found that for caregivers and for patients themselves, oftentimes they have a different perceived urgency if you present lab information in different format. For example, caregivers, oftentimes they want more accurate interpretation. So instead of using solid grading color, they oftentimes prefer to use solid color. And most of the patients actually prefer to have more risk-related labeling when appropriate for those labs that are indicative of certain risk of diseases, and also having a goal range set for conditions such as diabetes, where patients know where the goal value should be when they actually had a chance to talk to doctors. So in an online experiment with 130 participants, we focused more on providing AI-generated context information compared to generic information. So given 4 different patient vignettes with 2 different conditions, heart diseases and chronic kidney diseases and hypothyroidisms, we generated medium risk profiles and high risk profiles. And then we're randomized participants into different groups to evaluate whether contextual information can give them a better, more accurate interpretation of the urgency and the intention to follow up with their doctors. And currently we're analyzing the data. So I really hope that we can publish this study and so that we can learn a lot from this particular study. But our hypothesis is by providing contextual information with question prompt that are tailored by individual patients, the patient should have a more accurate interpretation. So in the back end, we also are developing this application, LabGenie, in our HIPAA-compliant Azure cloud environment. And this cloud environment allows us to use a private network with multi-factor authentications, encrypted storage, and continuous security monitoring. And we have built a full testing deployment pipeline and to enable smart on-fire authentication, so the system can pull real clinical data, including lab results, medications, diagnosis, encounters, and patient and care plans from electronic medical record data. And in partnership with Tallahassee Memorial Healthcare, we integrated the identified patient data to test our data pipeline and completed the necessary security and architecture reviews. So this will give us a good position to begin live data, fire data extraction for our project. And also, in order to make our applications more user-friendly, so we work with a company to conducted 2 rounds of design sprints to evaluate whether to make sure that the applications have a certain level of usability and interactions. So in the interface, the patients, when they log in, they'll be able to see the tailored information that are provided based on their information, and also questions they can follow up with their doctors, and also the general information about their blood results. And also they can look at lab results in different panels provided with visualizations, with definitions of labs, and also the indicator for indicating normal values or abnormal values. And also if they go to specific labs, they can also see the interpretation about their trend, historical information about their particular lab, and also the actions they can take to follow up with their doctors for next steps. And they can also see the visualizations for those labs over time, and also understanding where their value are at this point. And we have also developed a companion like mobile-based application. So using this second round design workshops, we have conducted two additional design workshops recently to evaluate system-level interactions and usefulness. And we found that the perceived usefulness, ease of use, intention to use scores are all above 4 out of 5, which indicates a strong indication that this is useful applications. In addition, we also have completed the development evaluation of generative AI-powered question generation module, where we want to make sure that we can have a clinician in the loop to help us evaluate how we can use generative AI models such as GPT, Llama models to generate tailored question prompt based on patient information, clinical information. And we ask questions about clarity, clinical appropriateness, and usefulness. And in each round, we ask patient providers to rate questions generated by AI for multiple patient profiles. And then by round 3, and we have reached to 100% questions being judged as clearly phrased and clinically appropriate. And then we proceed with patient evaluations. We recruited over 130 patients to evaluate these questions, and then using again like a scale to to make sure that the questions are understandable and useful for them. So this one just to show you information about the kind of different rounds of information generated based on our feedback from our clinicians. So as you can see, the first round and second round have a quite different style, where the second round incorporate more information about the patient's diagnosis and the medication use, along with the lab results. So we think that this one should give patients an even better understanding of the lab results and be able to ask questions in a meaningful way. So this slide shows the question evaluation module results. The second round questions rated by 3 clinicians on 3 different questions on likely to be asked in primary care, significance of patient health, likely answer, all rated above our acceptable thresholds value. And third round is slightly better because we also use the question evaluated in the second round to provide positive and negative samples to the models. The model can learn better what kind of questions should be generated and more favorable by doctors. And then when we move on to the patient evaluation part, we also selected questions for 3 patient profiles and asking patients about the reactions on understandability. And out of these questions, 25 out of 30 questions are scored over 3.5 for understandability, and over 20 over 30 questions are scored over 3.5 for usefulness, with a strong rating for questions focused on what they should be doing next, and also their lifestyle related questions. So at the same time, because of the growth of generative AI, we also have evaluated the feasibility of using generative AI technologies to help with differential diagnosis and also answering questions about patients related lab information. So the first study we published earlier this year in M.P.H. Digital Medicine, we focused on using published case report in PubMed and see whether adding the lab information or not would help with generating accurate differential diagnosis. So we can compare the generative differential diagnosis with a real gold standard published reported in the literature, and found that using lab information does provide a more accurate differential diagnosis prediction. And then in this study published in JAMA, we focused on looking at patient questions asked by social media platforms and see whether patients can, whether different AI models can provide a safe, relevant, useful, and helpful responses to these questions. And we found that some AI models such as GPT-4 provided even better answer than peer patient answer questions on social media. So this was study also shows the potential for AI in this space. So the key takeaway message from this talk is we really think that it's really crucial to engage patients in the early design phase for this type of applications to make sure that the features, interactions are acceptable by patients. And then we also have included clinicians in this loop to make sure that the information generated are accurate and tailored and useful for patients. We also think that perceived risk of our lab results could be very nuanced for patients and caregivers. And for frontier language models with sufficient clinician and patient input, they can generate contextualized, clinical, meaningful, and understandable questions about lab results. But certainly, we still have to put safeguards around those generated content because AI generated information could include still hallucination and confabulation information. And then finally, LLMs have the potential to support even more critical clinical decision-making process, such as differential diagnosis about lab results interpretation, to support more informed shared decision-making. So with that, I'd like to thank my teams, which includes both the human factor side, my co-lead, Dr. Mia Lustria, and also a wonderful team of researchers and developers, and also our advisory panel, which provides support for both the human design aspect and also the AI aspect, and also the translational aspect of this project. So thank our funding from AHRQ, and if you have any questions, please feel free to reach out to me. Thank you.
All right, thank you, Dr. He. As a reminder to folks, if you have any questions about Dr. He's presentation, feel free to put it into the Q&A panel that you'll see to the right of your screen. And let's see if I can get control of the slides to move it over. There we go. Okay, so let's move on here to our second webinar presentation, which is being led by Dr. Valerie Press. Dr. Press is a professor of medicine and pediatrics and the Associate Chief Clinical Transformation Officer at the University of Chicago. Her research is focused on developing, testing, and implementing patient and system-level interventions to improve the quality and value of care for patients with chronic lung disease across care transition settings. Dr. Press is a fellow of the American Thoracic Society and is a senior fellow of the Society of Hospital Medicine. She has authored or co-authored 118 papers in peer-reviewed journals, serves on the editorial board of CHEST, and is an associate editor for the Annals of the American Thoracic Society and the Journal of General Internal Medicine. Clearly, how she finds time to do her AHRQ study as well is tremendous. And so we're very happy to have Dr. Press here. Take it away, Dr. Press.
Wonderful. Thank you so much. And I want to echo my appreciation for having the opportunity to talk on behalf of our wonderful team doing this work. So we're really pleased to be able to share our work. As noted, I will be talking about our project that looks at telehealth enabled transitional care interventions to help improve our patients manage their COPD through medication adherence, reconciliation, and self-management education. we'll be focusing largely in the topic of chronic obstructive pulmonary disease, or COPD, and many of these individuals are older individuals and face a lot of the issues and vulnerabilities of that aging population. And some of the issues that we'll talk about can be unique to this population, but many actually can be thought of across various chronic diseases and even some acute care. And one of the most fundamental pieces of what I'll be talking about is related to our project is around transitions of care. And many of the people on this webinar understand that this is an incredibly vulnerable time when patients are admitted to a hospital. They're admitted, say for a chronic disease, it is an exacerbation of that disease. And so they are not doing well in some way. And we try to help make them feel better before we send them home. But they're not always all the way better. And they also have multiple other issues going on. And there may have been factors that were out of their control that led to the exacerbation. However, there could be factors that could help them avoid future exacerbations. And so this entire project is set in the foundation of thinking about transitional care models. And so TCM means a lot of different acronyms. Here it'll mean transitional care models. And so I'll try to say that out loud. And so what these models do are really try to think about the whole spectrum of care from when a patient is admitted all the way until they get home, and even after that, interacting again with the healthcare system, ideally in the ambulatory setting, hopefully, and not back in our urgent care settings. Why is this important for this population? Well, all individuals could have some risk with the transitions after discharge. There's a lot of information that needs to be known and follow-up care, but we know from literature that older adults have even higher risks of any of these vulnerabilities. And we know that in general, for chronic diseases, medication non-adherence can be a big issue for patients for a whole host of reasons, and self-management skills are not always robust. We don't always have the time to teach and reteach. And so together, these risks, vulnerabilities lead to adverse events, readmissions, and higher costs. And so we, in our COPD program, which I'll be talking about throughout, have a COPD transitions of care program that has been in existence for over a decade. We were looking for ways to enhance elements and gaps in this transition of care model. And so how can telehealth potentially support this? Well, if you had been looking at the diagram that I didn't go through specifically a moment ago in the transition care model, it's basically all these different elements of care: coordination of care, making sure patients have what they need before they leave the hospital, making sure they have what they need after they leave the hospital, staying in touch with them. And we can do that by phone, we can do that by follow-up ambulatory visits, we can do that sometimes for patients with home health. But telehealth provides the potential for ways to really help this transition of care model meet many of those criteria. So if you can meet patients in their home over video after they've been discharged, that helps with continuity. It helps identify needs for care coordination. It can help provide follow-up. We're hoping it can actually help address ongoing gaps and needs in understanding what medications patients should be taking and what help they need to take those medications. We know that on average, about 50% of patients discharged from the hospital will have at least one error in their medication plan on their after visit summary. And many of those are minor and easy to figure out, but some of them can be major. These televisits can directly link our patients back to healthcare professional without having to come back on site to the healthcare system. And as mentioned, we have a variety of tools that we can use through telehealth, and we can involve lots of different members of the care team. And so telehealth has a lot of potential. It's not perfect, which we'll get to. And so what is the potential impact of our research? Well, we are hoping that by implementing these telehealth visits for all of that potential after patients have been discharged from our COPD program, that we can use those visits with our pharmacists to help our patients directly understand which medications they should be taking, correct any misunderstandings or provide prescriptions if needed, help directly then lead to medication adherence and self-management education. And together, we hope that improves their health outcomes, both with reducing symptoms, exacerbations, and acute care utilization. So how can we use telehealth for these topic areas? And so one of the most critical aspects to medication adherence, although there are many, is making sure patients have at the ready the correct medications and they know when and how they're supposed to use them. And so for COPD, it's not unique to COPD, but it's a common issue with patients who require inhaler devices or other medications where inpatient formularies have specific availability of those medications, which may or may not match what the patients came in on. So a patient could have one type of inhaler coming in the hospital, get another type of inhaler that has the same medications but a different name, and then be discharged maybe on this new one, which may or may not work with their insurance, which may or may not be clear that it's the same as a different one. And so this role of having a pharmacist see the patient in their home, the patient can lay out all of their inhalers and other medications and really go through what are they, are there any duplicates, are there any missing? By reviewing the medication lists, it really helps avoid confusions, mistakes on both the hospital side of things, but also on the patient side of things. Patients also have questions that don't always get answered, or they have new ones once they get home, and they may want to know what are the side effects, or which one of these am I supposed to take every day? Which one am I supposed to take as needed? Patients learn a lot by connecting with their pharmacists, and by connecting them in this telehealth visit, it really helps solve some of these discrepancies really early on, right after discharge. And as I mentioned earlier, there's significant evidence that supports that medication reconciliation can decrease errors and improve safety. And so we hope that this role of medication reconciliation contributes to medication adherence to help our patients understand their medication plan, stay on the correct adherence plan, and lead to fewer exacerbations. Going hand in hand with any medication that has any skills involved, such as inhalers, as I've already mentioned, but you can think about this for other chronic diseases that involve, say, injections or anything like that. You often can't just tell a patient how to do this one time. And in fact, it's best if you show them how to do it, and you probably need to show them on repeat. So in our existing COPD program, we teach inhaler education to our patients while they're hospitalized, tailored to what inhalers they're supposedly going home on. And we have found, and I'll show you a little bit more about this approach, something called Teach to Goal. We have found that this health literacy sensitive approach is effective and more effective than other educational approaches, such as telling patients information, handing them pieces of paper with information on it. This is a more interactive approach, which again, I'll show you in a moment. And so both with the fact that their medications might change by the time they're at home, and then also the fact that we know that the skills, even if they master them in the hospital setting, they often need repeated education. We bring them back for outpatient visits, but by the time they get back to us, they may have already needed some practice. And so again, this role of a telehealth visit early after their hospital discharge could help continue their skill level. And so this really is an interactive approach that can help them build their confidence and understanding. And again, we know that these inhalers are effective at reducing symptoms and avoiding exacerbations when the medications make it into their lungs. So this could really help with long-term wellness. So just briefly, this is the Teach to Goal intervention. I know it has a lot on it, but let me describe it. So basically, if you look on the left, you see some arrows. And so the Teach to Goal approach starts by seeing, what is the patient doing? So often in healthcare, when we educate, we just sort of start at a certain level and go from there. Here we can see, are they doing a pretty good job, but just need a little tweaking? Are they struggling with many of the steps? So we can watch them. We can then provide very specific, tailored demonstration and verbal instruction to help them really get better at using that inhaler. And then we use this concept of teach back, which is one of the most effective ways to work across health literacy levels, is to understand, did we do a good job teaching? And so we ask them to show us again. And then we can go round and round. And what you see behind the arrows and also to the right are examples of checklists. So to understand if patients are doing this well enough, we have isolated discrete steps for each different type of inhaler. And what you can see on the right is we like to see how they're doing before we teach, and then we can do several rounds after. We have a goal of getting patients to do well enough technique, so it doesn't have to be perfect, and that cutoff is around 75%. That means that if patients are getting more than that incorrect, they are very unlikely to be getting enough medication into their lungs to be effective. It's not a perfect cutoff. Sometimes patients still aren't getting enough after that, but it's been a useful clinical approach without requiring absolute perfect technique. And so we knew that we wanted to enhance our COPD program where we saw patients in the hospital setting and in our clinic by introducing these at-home telehealth visits. And so we wanted to look to the literature, and I was lucky enough to collaborate with folks in the state of Washington on a rural COPD project where they actually helped develop a multi-session pharmacy-led inhaler education program with patients that were seen in their hospital but that lived quite a bit away. And you can see here that they did this teach to goal approach over video. They showed it to be feasible, effective, and it was very well accepted among the population. They were able to show improvements in inhaler technique and patient satisfaction across 2 different studies. And importantly, and this will be a theme with us, technology-based barriers can definitely occur. And depending on the range of support, can be addressed in different ways. Now, I will say for these projects, patients actually had technology devices delivered to their homes, and there was a lot of technology support. And most patients with that high level of support were actually able to participate. It was not 100%, but with a lot of support, this was actually very well received. Just very briefly on this work that was done, I wanted to highlight some of the evidence. So how did they do in terms of improving specific inhaler types? So in the greenish table on the top here, you can see a bunch of different types of inhalers, the range of scores, which represents the range of individual steps that were identified, and the number of individuals who had used each of these inhalers. You can see the pre-training and post-training median scores, which ranged, and you can see overall, except for one device, post-training scores improved. And not shown here is they were generally sustained over the duration of the program. Like I said, it was multi-session. I will note the one inhaler that did not show a significant change only had 3 participants. It was a meter dose inhaler, and other meter dose inhalers did show significant. So we have reason to believe it was an underpowering for that specific inhaler. Also, as important as showing us the technique when we want to think about adherence is really understanding how our patients feel about using these inhalers, and their confidence, again, really did increase. So using a similar type of design with each inhaled medication listed, we have baseline confidence scores and final confidence scores with also the change in score. And here again, most of the inhalers did show a significant improvement, with the only 2 not showing significant improvement, having a small sample size. Again, one of those being a meter dose inhaler where we were able to show significance in other devices, and one that was a dry powdered inhaler that also other dry powdered inhalers were successful. So that may also have been a powering issue. We wanted to take this work that was done in a rural setting with a high level of technology-based support and understand if and how we could bring this to our urban setting for our patients on the south side of Chicago who have a host of technology barriers, everything from digital redlining, meaning that the infrastructure where our patients live is not always as robust as the infrastructure in other parts of the city. So even if they have a smartphone in their pocket, or a laptop or some other computer, it may or may not connect sufficiently. So there's system-based errors, system-based barriers, and then there are also a whole host of other barriers that our patients face, such as maybe they don't have a quiet private space to have a video visit and other things like that. However, we didn't want to let our knowledge of some of these barriers dissuade us from trying to use this really incredible technology that has all the benefits that I mentioned. And here are some evidence-informed advantages that came out of the rural studies. So patients really appreciated when they were able to connect, having this as an opportunity to reduce transportation and scheduling barriers that are so common. If they connect, it's very easy to then participate. They really appreciated the enhanced confidence, which they directly linked to improved quality of life, which we thought could be helpful for the urban setting. The patients in the study had high satisfaction despite, as I mentioned, there were some technology issues, and that did not dissuade the patients in the rural setting. So we were hoping that would be true in ours as well. And then we were hoping in our evaluation to do a much larger study in this complex urban population to take all of this evidence that we've seen before and really understand how this could impact our program and the patients who get our program. So some of the key considerations, though, that we are constantly attuned to is how do we handle the coordination that's so necessary for transitions of care models, and how do we not ignore all of these disparities and issues faced around digital access and digital literacy. And so if our study goes well, we hope that we improve health outcomes after they are discharged by providing this ongoing support. We know that many of the rehospitalizations for COPD in the first 3 to 5 days are due to issues related to medications. And so if we can get to them very early, this can directly help with that. We know that we can help the quality of life for patients when they're starting to feel better and they're less stressed. It's a great time to try and continue to build self-management skills. And we want to help our older adults stay healthier after leaving the hospital so that they don't have to come back too soon. This reduction in adverse outcomes and hopefully improvements in health outcomes could help us overall with our patients. And I wanted to take a moment to really bring into focus how our specific AHRQ funded research program in telehealth meets several of the actual COPD global quality standard position statement elements, because we want to make sure that what we're doing is aligned with our clinical guidelines. And so there has a very large focus on several of these components listed here. Diagnosis is not a topic for today, but as you know, it can be imprecise in COPD. But the rest of them, we really feel like we could address. Adequate patient and caregiver education. Adequate means not one and done, not never, and then also done in the right way at the right time. And so that often means this teach-to-goal approach over multiple settings with both the patient and any of their caregivers. We want to make sure that they have access to the medical and non-medical treatments that are aligned with the latest evidence-based recommendations. And it says here, with appropriate management by a respiratory specialist. So that can be everything from a pulmonologist who's helping to lead our inpatient consults and supervise our outpatient visits, to our pharmacists, who are respiratory specialists in the respiratory medications. Obviously, with the transition care model, appropriate post-exercer management is exactly aligned with our program. And then this helps introduce additional opportunities for the patient, caregiver, and follow-up. So our simple intervention of adding telehealth visits with the pharmacist to our existing COPD program aligns with this global statement. And so a little bit more on our specific project. This is our case study. We aim to have a pharmacist-led program, which I've been talking about. We knew that we wanted core components around medication reconciliation for our patient safety issues, COPD education in general to understand how to link the medication reconciliation to adherence, and then specifically inhaler training. We used a user-centered design to help understand what are the workflows that are appropriate and ideal for our patients so that we can get improved self-management. So if you look at this diagram, in gray are elements of our existing program. So patients get admitted, and so before discharge, as I mentioned, we do medication reconciliation and inhaler education. Patients are then discharged. We provide a phone call by a nurse member of our team who can help identify if there are any issues with medication prescriptions and other key barriers. And then within 2 days before the first scheduled telehealth visit, which again is a televisit with our pharmacist, our approach using this patient-friendly workflow user-centered design method identified that patients would prefer text or phone or email and at most 2 reminders. So we would do that for them. And then on the day of the televisit, we identified that the preferred mode would be synchronous with video support. However, many of our patients are not able always to use our patient portal. And so we were able to identify additional opportunities through Zoom and Doximity and other ways of doing the video visits in a way that works for the patients. And then we wanted to know how many times did they want to meet with our pharmacist, and they asked for 2 to 3 follow-up visits. We try to get the first telehealth visit before our outpatient, again, to get those early days where medications are often the culprit of ongoing issues. And then we like to see them at least once after our outpatient visit. I will say at the outpatient visit where they see our advanced practice nurse, they do also get inhaler teaching. So this provides an opportunity for multiple rounds that is aligned with the multi-round approach that the rural program took with their pharmacists. In this case, it's often with different settings, but still with our same pharmacy team. Additionally, not all patients make it to their outpatient visit, and so this is a way to also do multiple visits with them at home before they make it to their next primary care visit and or pulmonology visit. We spent a lot of time talking with our patients. We spent a couple of years doing multiple rounds of user-centered design, and I wanted to highlight the key issues that rose from our patients and our clinicians who we talked with. They want it to be seamless. They really want this to feel like it's all part of the same program with the same care team, not that it's this fragmented piece of care. And so we introduced things like warm handoffs where our pharmacy team could meet the patients in the hospital. We could help them understand how to use the digital technology that they might need to use. They want it patient-centered, and so we needed to understand how to do this with patients who had some of the barriers that I mentioned, and how to do workarounds. We wanted to make sure that they understood this is complementary and not a replacement for any of the other visits that they're supposed to do, because we didn't want to confuse them on that. And then as we talked already about the process flow, we worked very closely with them on that. They enjoyed that it was multi-component. They felt that was a lot of value and further justified having multiple sessions. And then they gave lots of advice to how to successfully implement and adopt the rural approach, which strategies to use to help them feel comfortable in the visit. And so what we learned, and we built and piloted the actual sessions with real-time Zoom supplementing also the video visit, where we had our pharmacist and our patient participant in the pilot teamed up together. So we could learn a lot about how our system, which we built in Epic through MyChart, and then with our workarounds if needed, really worked in real time. We were able to then further edit our program so that it was optimized for the randomized study. We're currently running the randomized study. It is almost halfway through recruitment, which is amazing. And so in order to get to that phase of the study, we learned that we were taking an approach that aligned with our patients' wishes, that it was a dedicated care transitions team for that seamless coordination, that the telehealth visits could be flexible around their schedule, that we gave appropriate clinician training with our pharmacy team, but importantly, that patient warm handoff while they were still in the hospital. We can also do technology visits with them outside of the hospital if they need support prior to their visit. And then we had ongoing challenges that we knew to look for in the randomized trial, where despite all of this, we know that some of our patients are not going to be able to address the digital literacy and or access issues. Importantly, the pharmacy visits are considered ancillary visits and are not billed for. And so this is actually a way that our patients should be able to maintain care without actually having to worry about insurance for specifically the pharmacy visits. So our challenges that we anticipate for our trial is still around the attendance. So again, despite all of this, and this is due to some of those system-based barriers that we already mentioned, where despite all of the patient's engagement and interest in participating, it may be infeasible. We can use phones to check in. We won't be able to do all of the visual part of the visit. But they also helped us identify all of the opportunities I've already mentioned, how to stay in touch with them, what are their preferences, and how to strengthen this continuity. And so in theory, telehealth should be simple and easy to use. In practice, it is not always. It is not always easy for older patients. It is not always easy for any patients. It is not always easy based on technology barriers. I myself could not get on a video visit the other day. Apparently, it was because I hadn't updated the software on my phone. So we have lots of things to work on to make sure telehealth is accessible to everyone. We need to tailor these visits to our patients. Some of our most high acuity patients probably need to be coming in person much earlier than the standard time period. Not to say we don't do telehealth visits, but we want to keep that in mind. And then we need to help our patients understand what is going to happen during a telehealth appointment so that they value it. If we just say you're going to have a video visit, they may not know what it's for and they may feel, I'm feeling fine, I don't need it. But if we tell them that it's for this education and to check in and make sure all the medications are correct, they become much more engaged. For longer term wraparound program issues, the patients were really interested in the insurance cover issue, and they were really happy to understand that they could still do these visits regardless of insurance. And of course, as you're rolling out anything in the real world, we needed to understand how our clinicians across the institution would interact with this project. So telehealth can help with this transitional care model that I described to help fill in gaps, help check in on patients, and help them feel like they have continuity of care in an otherwise confusing state. We can use these telehealth visits not just for the traditional use, which is an actual clinic appointment that's over video, but actually for some of this supportive care that we don't always have time for in other settings, or that's not always the ideal setting. When they're really sick in the hospital, it may be harder to remember what we're teaching them. And we're hoping that by continuing to supplement our program and wrap around these programs for our patients, that we can really help their outcomes. I want to thank the entire team. This is a multi-PI project. Dr. Vinny Aurora and Dr. Joanna Abraham are the other PIs. We have a wonderful team who work with us to support this program and additional co-investigators. But that is my time. I'm happy to take questions when we do the Q&A or in the Q&A online portion. Thank you.
Thank you, Dr. Press. And just like she said, if you have any questions, please use the Q&A box over on the right side of your screen. And I know Dr. Press will work to hopefully start answering some of these questions. Okay, let's see for the next slide. Okay. Moving on to our final presentation of this webinar is being led by Dr. Jorie Butler. Dr. Butler is an associate professor in the Department of Biomedical Informatics and the Department of Internal Medicine Division of Geriatrics at the University of Utah. She's also the associate director for education and evaluation in the VA Salt Lake City Geriatric Research, Education, and Clinical Center. Her research interests include socio-technical systems and implementation science of patient-centered care, geriatrics, and medical decision-making. Dr. Butler focuses on the goals and personal experiences of patients and how clinicians obtain and use that information to encourage active patient involvement in patient-centered care and shared decision-making, particularly for older populations. And now I would like to turn control over to Dr. Butler.
Thanks so much, Kevin, and I'm delighted to be with you all today and hear about these great projects. So I'm discussing our AHRQ funded study that's focused on building an age-friendly learning healthcare system. This is an MPI project where I'm working with the unparalleled Ken Kawamoto. Ken handles technical tool development and integration, and I work on the socio-technical systems elements, including understanding content needs and implementation needs. We have a fantastic team. 3 dedicated geriatricians are working with us, Megan Puckett, Mark Supiano, and Tim Farrell, who serves as the Geriatrics Division Associate Chief for Age-Friendly Care at University of Utah. We've got a terrific manager, Rachel Dalrymple, who keeps us on track, and 2 developers, Claude Nonjo and Phil Warner, who are building our tools. There is a shortage of geriatricians nationwide, and this coincides with the tsunami of older adults in the U.S. due to demographic changes. So to address this need for geriatric care, the Institute for Healthcare Improvement spearheaded an initiative to improve care for older adults across healthcare settings, the age-friendly healthcare system. The cornerstone of the movement is holistic care, similar to a comprehensive geriatrics assessment. And the IHI goal is that every healthcare encounter for adults age 65 and older include care organized around 4 key elements known as the 4 M's. So those M's include what matters, older adults' specific health outcome goals and care preferences, medication, so that medication does not interfere with the other M's and is safe for older adults. Mentation, the prevention, identification, treatment, and management of dementia, depression, and delirium across care settings. And mobility, which is ensuring that older adults move safely every day. Our study is focused on the development of integrated, interoperable point-of-care digital tools related to 4M's care. And these tools hold promise for enhancing shared decision-making in age-friendly care, advancing clinical practice, and enabling measurement of patient-centered impact for improved outcomes. In this work, our goal is to provide key information and novel information to clinicians to enhance their mental model of their patient and improve decision-making. Our project is not only age-friendly, it's also organized around the paradigm of a learning healthcare system. The learning healthcare system is a translational science approach where we can use data that's collected through healthcare based on an encounter, and those data can be assessed to inform intervention design in a dynamic and continuous cycle, facilitating a culture in which clinicians can learn from every patient. In order to develop an effective, scalable, age-friendly learning healthcare system, it's essential to have electronic health record-based metrics that assess the implementation of age-friendly care. In prior work by our team, we replicated some EHR metrics for age-friendly care in the inpatient setting. Those metrics were developed by University of California, San Francisco, and we applied those metrics at UHealth. In our current study, our group has developed EHR-based metrics for age-friendly care for the primary care setting based on the recommended 4 M's assessments and actions. These measures will be able to be adapted to other outpatient environments and will contribute to the scaling of age-friendly care. This depicts our age-friendly learning healthcare system model. Our intent is to continue to expand our capacity to collect age-friendly care data to inform both our current intervention as well as future interventions. These are the specific aims for this project. So in the project, we plan to develop prototypes for EHR integrated age-friendly digital tools, to integrate those prototypes into clinical care, and then to deploy the tools into multiple clinics. Our goals for Aim 1 are to develop a prototype tool that includes information about a patient's 4 M's care, incorporates 4 M's patient-generated health data that can be collected from patients in a non-burdensome way, and is identified by clinicians as valuable via participatory design. In the first step, we developed and examined EHR-based measures of 4 M's care in outpatient environments. Next, we worked with patients in geriatric clinics to collect their 4 M's PGHD, patient-generated health data, using a mobile application and to characterize their experience, both with contributing the PGHD and using the app, as well as to explore alternative collection methods. Then we conducted a round of participatory design with clinicians, where clinicians evaluated a mock-up of the prototype and reviewed a full suite of 4M's PGHD elements and prioritized those for clinical utility. To develop EHR-based measures of age-friendly care, we were guided by the IHI recommendations for ambulatory care environments. So the left column shows the recommendations for assessments, such as inquiring about what matters to an older adult and documenting their preferences, such as in an advanced care plan, or screening for dementia with an approved screening measure. In our system, the measures that are regularly used that match recommendations were the mini-cog or the Montreal Cognitive Assessment. Then in the right-hand column, we see recommended actions that are proposed when warranted. So you can see, if you look at the specification for screening for dementia or cognitive impairment, it says, we can see that there's a specification that says if the screen is positive, then the action is warranted. And this is important to note. Assessments are recommended to be performed on all patients 65 and older at least annually. But actions are recommended only when warranted by the patient's state. So we applied the EHR measures to both the geriatrics and primary care clinics to get a feel for the level of 4M's care that's happening now. At our site, we have nearly 3,000 patients who are seen primarily in geriatrics clinics and over 33,000 who are age 65 and older who are seen primarily in primary care clinics. We reviewed the proposed measures with our geriatrician team. We focused on structured data in the EHR or limited text searching as measure components. And then we applied the set of measures we developed that are replicable within any EHR system to the ambulatory clinics in our system to understand adherence to recommended 4M's practice. So here you see the percentage of clinic patients who have had the recommended assessments and actions by M. So for the What Matters assessment, across a one-year period, 72% of patients in geriatrics clinics had an advanced care planning document complete and up to date, and less than 20% of the patients 65 and older in primary care also had this assessment. For actions, for other M's, the mentation M assessment is calculated using the denominator of all patients. So the 72% here is 72% of all 3,000 geriatric patients. But for actions, we're focused only on patients for whom the action is warranted. So we did not only use screening results to determine whether action was warranted based on geriatrician recommendations. We dropped the denominator to the numbers that you can see at the very bottom line. And these are patients who had an ICD-10 code indicating dementia. So the action metrics, like beginning with having a visit related to dementia, that's 90% of 599 patients in geriatrics clinics. And this is a look at the mentation depression data. Patients in primary care clinics who are over 65 actually had a higher rate of screening. This is likely due to robust depression screening protocols in primary care. And again, the denominator drops, and the recommended actions related to depression apply only to patients who have an ICD-10 code indicating depression. And I should note that although I said there are more, and it does look like it is, a higher percentage, we didn't do any significance testing. There's no statistics applied here. These are just descriptive data. All right, so for medication, the assessment measure is medication reconciliation, and this is nearly universal across clinics. But patients who are not prescribed any medications that are considered high risk for older adults, like similar to the medications on the Beers list, if you're familiar, which is a list of medications that function a little bit differently in older adults and are contraindicated generally. So the patients who are not on any high-risk medications it's slightly higher in primary care, and that's likely related to the more complex patients who are referred and managed in geriatrics clinics who may need specific medications where the benefits outweigh the potential harms. The mobility assessments that were used include the timed up and go test, 5-meter walk test, and multiple types of falls risk assessment. This was performed more often for patients in geriatrics clinics. The action denominator is based on patients who were designated high risk for falls based on these assessments. So individual M's had reasonable rates of adherence to recommended care practices, not perfect, but okay. But when you look at whether assessments were completed across all 4 M's during the year for specific patients, you see a steep drop. So for the M's, and then for the M's where an action was warranted, fewer than 20% of patients had all actions completed. The proportion of 4M's assessments and actions that have been performed are a crucial component of our provider-facing tool to assist providers in decisions related to 4M's care. In addition, we also collected a set of Ph.D. related to the 4M's. So we see here that even geriatricians are not adhering to the 4M's practices as much as we would expect. So that makes this an excellent setting to deploy a 4M's based tool intended to support improvement in adherence to 4M's care. And this tool could also be implemented in primary care environments as well. Our next step was to collect 4M's Ph.D. using a mobile application and to examine participant experience and explore additional collection methods. So this image shows a prototype of the summarization screen of our mobile application for collecting Ph.D. This image here is a version a bit closer to the final. And so you can see the structured survey measure scores are organized by M. We had open-ended questions with responses and prompted photographs taken to highlight potential issues such as mobility hazards in the patient's home. I want to acknowledge that this slide is not great. When the provider views the mobile app, the summary screen is easy to read and is big enough. We just had a little trouble getting it into a slide. Please direct your attention to the top left. Under the purple Save Data button, there are 2 mentation measures, one of which is a standardized measure of anxiety, and you can see that this is yellow, indicating that the score is in a borderline range, similar to the displays that Dr. He developed earlier. Depression is green, indicating that the patient is in the normal range and is not depressed. This shows the list of specific photographs that we requested that patients take, and the prompts included home entryways and specific living areas like the kitchen. So we collected Ph.D. from 16 patients and conducted a series of small group interviews with patients who contributed Ph.D. and then conducted a thematic analysis. Our results showed that contributing data via the app was feasible, generally acceptable, and patients were very interested in their PGHD. They thought that physicians would find the information interesting, but might be too busy to look at it. And in general, the patients thought that they would be able to contribute this data using an alternative method, like through the patient portal, which in our Epic system is the MyChart portal. We also conducted a second thematic analysis on the group interview data using a large language model with the human in the loop. Our goal is to develop some standardized methods for LLM-assisted socio-technical analysis for high quality and rapid evaluation in this project. And this was our first attempt, led by a student who worked with us this past summer. A human was in the loop throughout the LLM-assisted process. In the code generation step, we provided individually each of the 16 de-identified transcripts. They were run separately through ChatGPT, the 4.0 or 4.5 model. Each transcript was coded separately with specific quotes relating to the codes. Then in the code refinement step, codes were run through ChatGPT with a prompt focused on combining similar codes and creating a refined list. The human lead then standardized any terminology and provided the code and quote list to ChatGPT with a prompt instructing the model to generate 3 themes characterizing 3 distinct groups. The 3 human-coded and synthesized themes are presented to the left and the LLM-assisted themes to the right. We used cosine similarity to assess agreement between human-coded and LLM-assisted codes and themes. Precision was 100%. All codes identified by the LLM-assisted coding had at least one corresponding human-generated code. And recall was 88%, the proportion of human codes that matched at least one of the LLM-assisted codes. All code level similarity scores were between 0.7 and 0.83, and all theme level similarity scores were 0.80 and above. And manual human review confirmed consistent coding and thematic boundaries. This depiction just shows the time spent for manual coding, a cost at over at nearly $2,000 for labor, and then the LLM assisted time and cost, the total cost, $236. Because a student was the human in the loop for the LLM analysis, we also demonstrated cost savings if a higher paid program manager would have been the LLM leader. Potentially an experienced program manager would be faster, but we assumed equal time and the cost was still approximately 1/4 of that of the human analysis alone. We anticipate that we're going to continue to develop and refine LLM-assisted methods, and these procedures may be useful for other teams. The paper with these results is currently under review at JMIA Open, and we'll continue to develop these measures to rapidly analyze feedback during the pilot year. So up to this point, we've developed EHR-based metrics. We've examined adherence to 4M's care in multiple clinics. We've collected and evaluated the experience of 4M's PGHD contribution. And next, we turn to the clinician phase of participatory development. In this phase, we aim to elicit clinician participation to understand their thoughts about the 4M's prototype tool and to understand what they thought were high utility 4M's PGHD elements for further design refinement. So we recruited 15 clinicians who care for geriatrics patients, conducted some semi-structured interviews, and had them view the digital tool prototype. We also conducted a survey where they ranked 4M's PGHD elements by clinical priority. So this view shows the mentation and mobility M view of the prototype. So you can see that there's a PGHD element related to medication, where the patient stores their medication. We also conducted a usability evaluation of the prototype tool. And this is the second half of it, showing the mobility and mentation. It gives them some guidance too of what actions to take. We asked clinicians to rate the prototype using the system usability scale. This scale has been used to evaluate thousands of tools, and there's an average score across tools of 68. And our results showed that the prototype was rated above average with the SUS, and we expect that to rise in subsequent evaluation of the refined versions of the tool. So what are we up to now? We're currently analyzing the clinician interview and survey data related to clinicians' preferred Ph.D. elements, which will influence the design of the electronic prototype and which 4M's Ph.D. elements are included. We plan to finalize an electronic prototype over the next 3 months, and then we'll pilot that in a single geriatrics clinic for 1 year, then implement in multiple clinics in the 2 years following the pilot. We'll assess the impact on age-friendly care as measured by the proportion of patients who have all 4M's assessed and warranted actions. This project takes a village, and we're just really grateful to AHRQ for giving us the chance to do this work. This is my contact information. Happy to talk more about our study and plans for additional work. Thank you.
All right, thank you, Dr. Butler. And thank you again to all of our presenters for their very informative presentations. You may see some folks have already had questions. So again, this is a reminder for the Q&A section coming up. Take a look at the panel over here. Let's see. Oh, there we go. I got control. Take a look here at the panel over at the right side of your screen. If you have any questions that you want to submit, I can see already some of our presenters have been busy doing their best to go through and answer some of the questions that you've posed to them. So again, if you have any questions, feel free to go ahead and type them into the Q&A section of the WebEx portal. And again, if we don't get to all of them today, we will provide responses to all the questions in writing, and you will receive an email once these responses are available, along with, I've seen some questions up here as it relates to, yes, the slides will be made available as well as this recording. And we'll send an email out once that is all ready to go. So with that, and I'll ask our panelists, if we see anything, questions that might come up or that haven't been, answered, we'll do our best to answer that. And since Dr. Butler, so Dr. He and Dr. Press both were, kind of answering some questions. And so obviously Dr. Butler didn't know how to wait in order to ask questions to Dr. Butler. And so I'm going to go ahead. I'm seeing this first long question kind of off the top, and I'm just going to read it to you. So I'm going to start off. So you'll get the first one here, rapid fire. If more health products designed with the 4M's framework in mind, it would likely lead to better health outcomes. Building health literacy and patient empowerment combats learned helplessness of most patients who cannot speak about their own conditions. The engagement that health care plans are a partnership with their PCP and care team is something that is deeply underestimated. To all panelists, what can we do to support your work if we hope to show up better for older adults in our own organization? Dr. Butler, I'll let you start first, and then we'll go down the line.
All right. I'm sorry, I missed the question.
If more health products designed with the 4M's framework in mind, it would likely lead to better health outcomes. Building health literacy, patient empowerment can can combat learned helplessness of most patients who cannot speak about their own conditions. The engagement that healthcare plans are a partnership with their PCP and care team is something that is deeply underestimated. To all panelists, what can we do to support your work? And the second part, if we hope to show up better for older adults in our own organizations.
What a great question. So a couple of things in relation to the age-friendly healthcare system. IHI does have a really active website with information about how healthcare systems can become certified in age-friendly care, and how to involve healthcare system providers in learning communities and other aspects, which is a great thing. And I love the thought of additional support for our work. So I'll have to give that some thought.
Okay. I'm just going to move across my screen here. So Dr. Press.
I think supporting this work from those interested is doing what we're doing, which is delving into technology in this population to not avoid using technology for patient population where a lot of people have learned helplessness and just think, oh, they won't do it. But I do think that it's important to be really intentional and understand the limitations. And I always get worried when technology options are the only option. And so those are the two most helpful, I think, things to help in this generally in this space. Specifically is just to keep doing this work and sharing it. I was honored to be able to share some of our work today, but a lot of people who are participating in this webinar is also doing great work out there. So thank you.
All right, Dr. Heath.
So in my view, I think we should not make presumptions for older adults. I think nowadays with technology advancements, a lot of people actually are pretty used to using technologies to help managing health data and also accessing health data. So I think as long as we can make these technologies usable and user-friendly, and also making sure that they are easy to use and understandable, I think they will be able to leverage these technologies to help better management of care. I do think that in this particular mobile applications we are developing, engaging clinicians, patients, and also various stakeholders will be important because we're hoping that patients will be able to using technologies to help manage data from disparate sources, as we have a relatively heterogeneous kind of healthcare systems here. So with that technology, I think patients, if we have better access to data in a more homogeneous way, it's easier for them to make more informed decisions about their healthcare. Thanks.
All right, terrific. And I want to stick with you, Dr. Heath, for one moment. And just out of curiosity, what kind of feedback have you been receiving from healthcare providers as it relates to integrating LabGenie into routine clinical, workflows as you're heading to that point? And this is a common thing now across a lot of healthcare systems and some use of either tools and especially tools that might be incorporating aspects of perhaps LLMs or generative AI.
So I think the feedback we have receiving from the clinical communities are pretty positive, but not without caution. They oftentimes have conveying some sort of concern regarding the advice we're providing to patients, whether they kind of sort of kind of do things something that is sort of shouldn't AI be doing, for example, providing medical advice. We certainly want to be very careful about not providing any diagnostic traits or any treatment pathways in this kind of information to make sure that patients are not really making those medical decisions just purely based on like what we present in this particular application. I think it is really important to be very careful about the AI generated content because of this potential hallucination and inaccurate information being generated. So we're now trying to sort of take a step back to figure out, for example, once we take medical information from patients, how can we categorize information into different risk levels? And based on different risk levels, we can tailor messaging based on what information we should be providing to patients so that they're not going to be just making decisions without their doctors. So there's a lot of nuances in this in our process. I feel like when we actually get involved in this project, by engaging clinicians and doctors and the patients, we learn so much about the project, and the work keep evolving. So it's just like ongoing effort. But I appreciate all the feedback from everyone. All the people in the state, all the stakeholders.
Yeah. Dr. Press, I have a question for you, since you've done so much work initially as it relates to this research, starting off in rural areas and then transitioning over to more, urban, areas. And as it's, grown, other health systems, right? Maybe trying something similar or thinking about it. And I was hoping you might be able to provide maybe a little insights for how can health systems scale and sustain these, kind of telehealth transitional care models,
Yes.
especially given reimbursement limitations. And, I'll put a plug in, though, as well for some of our sister agencies out there, such as CMS and others, and there's a lot of initiatives happening right now, such as the Rural Health Transformation initiative, their access, program. And so, we definitely see an enhanced, interest and finding perhaps initial solutions like you might have, Dr. Press. And, so how might others help, scale these?
Yeah, no, it's a great question. And I think some of the questions were sort of alluding to that. So there's so many elements that go into doing the telehealth visits. So, for those that are interested in this but don't focus on COPD, I was trying to explain that the lessons can be learned beyond COPD, for instance. And so I think what has worked for our program has been to have specific team members having specific roles to help allow us to be nimble, to do education, and to not have the program kind of change on its own. And so somebody was asking about, how do the pharmacists have time? We use a combination of resources such as pharmacists who have limited time. They're, not trivial cost resource. We also have an opportunity at our hospital where we have pharmacy students that work with our pharmacists. And so sometimes you can find value added roles, and that may not be with pharmacy, it may be with nursing students or other students. And so that's one real way that can help implement some elements of the patient education. Our inpatient pharmacists have time dedicated to our inpatients, and we were lucky enough, since this is an inpatient to home program, to get a little bit of their time to try out these telehealth visits. Now, we have to show in the trial that we're supported by AHRQ, which we're really grateful for, when and how to do that. And we may find, as people are pointing out, a lot of our patients don't have digital literacy or digital access. Maybe what we could do in the future is identify who are the highest yield individuals for whom we can carve out some time from our pharmacists, but not necessarily have to use all of their time for these visits. And so I think it's about finding synergies with your hospital. COPD was a good program for us because of the hospital readmission reduction penalty. A lot of hospitals are trying to avoid penalties. So what alignment can you find with your institution? What resources already exist that you can harness to really try and help make this sustainable? And for telehealth specifically, someone asked about the other program in rural. We did not provide high technology, like actually giving them devices or providing IT support, but we did build in our team real touch, in-person or by phone technology support. So what can you provide to help make these aspects feasible?
Exactly. Meet people where they are.
Yeah.
We just hit the 3 o'clock mark, so I know that means that I'm going to have to wrap up here. Let's see here. First, let me jump ahead. Okay, obtaining CME credits. So as I said, we reached the end. Thank you for attending. For those interested in obtaining continuation credit for participating in this webinar, please visit the URL shown on this slide. And you'll select today's webinar, which will be indicated by date and title to claim your credits. You have 14 days to claim your continuation credits, so make sure you set a reminder. And upon exiting today's webinar, AHRQ will also be fielding a brief evaluation, and we hope that you'll take the time to complete this survey to share your feedback with us. Also, I do want to give a quick shout out to Dr. Butler, whose project is looking at methods. Speaking of methods, and some of the tools that we have out there now as it relates to AI, LLMs, and the cost of what it takes to do research. And, I think that was a special wrinkle about your presentation, and certainly something that us as a research agency is very interested in as we look to do critical things, speed up how long it takes to do research, cut costs, find real value. And so I want to thank her for pointing that out. And if you have any more questions about that, and I'm sure Dr. He and others likely have similar insights. And it's just now that we're talking a little bit more about them. But I want to thank them. I want to thank everyone again that joined us today. And I hope everyone has a warm, healthy, happy, and safe holiday. Thank you.